For joining us this afternoon. Today, we are here to explore new developments and possible solutions for addressing America's substance use disorder and drug overdose crisis. Nationwide, there is an ongoing need for improved substance use disorder treatment. In addition, nearly 74% of all overdose deaths linked to cocaine now involve synthetic opioids such as fentanyl. This type of combination drug use is part of a new trend driving the overdose rate along with the growing use of xylazine or tranq. The extraordinary speakers we have with us today bring a wealth of knowledge about understanding, addressing, and possibly solving many of the issues related to the overdose crisis and ways to provide better care and more effective methods of substance use disorder prevention. Our panelists are leaders in their fields who will bring us the most current information and data on the policies, community-based practices, and healthcare industry practices that will produce a positive impact. But before we hear from them, I want to take a moment to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped convene today's event. You can find biographical information for our speakers, along with today's agenda and copies of their slides on our website. We also invite you to join the conversation on Twitter using the hashtag Combination Drug Use Webinar. After our speakers have completed their presentations, we will have a brief quick Q&A if we have the time. Now I would like to introduce our first panelist, Cecilia Spitsnaz, PhD. Dr. Spitsnaz is the Senior Science Policy Advisor at the White House Office of National Drug Control Policy, ONDCP, a component of the Executive Office of the President and Acting Assistant Director of Translational Research, U.S. Emerging and Continuing Threats Coordinator. As Senior Policy Advisor, she provides policy analysis and scientific advice for the ONDCP Director, Chief of Staff, and the Senior Policy Advisor for Public Health on special matters of concern. Dr. Spitsnaz's extensive federal career includes a 12-year tenure at the National Institutes of Health's National Institute on Drug Abuse, NIDA. While at NIDA, Dr. Spitsnaz oversaw extramural research on addiction treatment development and provider training, and especially the provision of these methods on computerized and mobile platforms. Today, she is going to discuss the latest federal priorities for addressing the overdose and addiction epidemic, especially new work addressing drugs used in combination and treatment efforts. Dr. Spitsnaz?
Thank you, Sherry, for inviting us, and also to the NIHCM organizers for putting this webinar together. And thank you to everyone who's turned out today. This is a really important topic. As Sherry mentioned, the Office of National Drug Control Policy, ONDCP, sits within the Executive Office of the President and leads and coordinates the nation's drug policy to improve the health and lives of the American people. ONDCP accomplishes this through 5 different main actions: developing and overseeing the implementation of the National Drug Control Strategy document, developing and overseeing implementation of the National Drug Control Agency budgets, which include 18 different federal drug control agencies, participating in regulatory decision-making and federal clearance process concerning documents and rules having to do with drug control policy, administering grant programs, including the high-intensity drug trafficking areas grants, the drug-free community grants programs, and the model state law grant program. And the links for these will be in my slides. The Legislative Analysis and Public Policy Association currently holds the model state law grant program, and they are the link for their association, so you can see what model laws have been made through ONDCP funding is available. Next slide, please. I'm going to try to set the stage for the circumstances that we find ourselves in by going over a few data slides for you. I don't want to be overwhelming with this, but this first slide shows the breakdown of the different substances that are involved in deaths, including synthetic opioids and fentanyl. And you can see that there's been a dramatic uptick in the synthetic opioids and fentanyl category. And these different categorizations are not mutually exclusive. So one person could be represented by psychostimulants and the synthetic opioids. Also, this doesn't show the synthetic, the natural and semi-synthetic drugs that are most of the opioid misuse from prescribed opioids. Next slide, please. In terms of drug use itself, past year illicit drug use, you can see that about 24.9% of people had a past year illicit drug use problem. And again, these numbers on the right-hand side of the chart are not mutually exclusive. People could be represented in multiple of these, but you can see that two of the largest categories, hallucinogens and pain reliever misuse, are both rather large. Cannabis, marijuana is the largest, but we also see quite a bit of prescription tranquilizer, sedative misuse, stimulant misuse for prescribed stimulants like the attention deficit disorder medications. And I want to mention, you see down below, heroin is only at 1 million. There's a new number from the national survey this year, and that is 680,000 past year fentanyl users. The thing is that we think that in terms of both the heroin figure and the fentanyl figures, that these are dramatic undercounts. The National Survey on Drug Use and Health does not include people who are unhoused or people who are living in institutional settings. So these numbers are most likely low. And in addition, because fentanyl is often used to contaminate certain substances, it's unlikely that people really truly know if they are using heroin or if they're using fentanyl because of the contamination issue. Next slide, please. Now, this slide looks at past year substance use disorder among people 12 and older, and you can see that 17.3% of people have a past year substance use disorder. And alcohol use disorder is largest, but that's followed by all of the drugs combined in drug use disorder, and they're pretty close. So 27.2 million people having a drug use disorder. And again, these numbers, especially for heroin use disorder, we believe are an undercount. Next slide, please. This slide looks at people who received substance use disorder treatment in the past year among people who are 12 or older who needed it. And you can see here, only 24% of people who are 12 or older who were classified as needing treatment received treatment. The parts on the right break them down by age, and you can see we're doing a little bit better at getting 12 to 17-year-olds into treatment, but we're doing really poorly getting 18 to 25-year-olds in treatment. And same for, I mean, across the board, we need to get more people into treatment. We cannot fix a disorder that we don't treat, and we're not treating nearly enough people. So treatment is a huge priority for us. Next slide, please. So saving lives is the North Star of the National Drug Control Strategy. If you look through the document, you'll see that we have both supply reduction and demand reduction sides of our drug policy, but saving lives is behind all of our goals. Next slide, please. So this lists all of the different National Drug Control Strategy chapters. A lot of people just go in and read a chapter that they think pertains to their area of work. I'm going to focus today on the harm reduction and substance use disorder treatment chapters, but you should know that there's a lot of other ones that are very relevant to public health, and those all have a check mark on them. Next slide, please. So what do we mean when we talk about harm reduction? Harm reduction is an approach that emphasizes working directly with the people who use drugs to prevent overdose and other harmful things that may happen as a result of drug use, including contagious disease transmission, social well-being of those served, and offering flexible options for accessing treatment. You might hear about low barrier to entry treatment and other healthcare services. The National Drug Control Strategy includes 3 main topics under harm reduction. It's not to say that there aren't other harm reduction types of activities, but there's 3 that we are specifically trying to raise awareness about through this strategy. The first is a provision of overdose reversal medicines. Many people have heard about the medicine naloxone, which reverses overdose. There's a new medicine that has been approved by FDA for treatment of overdose called nalmefene. And so those medications are very important. It would be really helpful if the insurance plans could elect to cover over-the-counter naloxone, which was recently approved by FDA, and continue to cover the prescription formulations, because these different products seem to be work for different patient populations. Different patient populations prefer them, and we want to make sure as many people as possible can continue to get these medicines. Test strips are available for fentanyl and for xylazine. Those are discussed. Those are ways of letting people take responsibility for their drug use situation and determine whether or not the drugs they're using may be contaminated and too risky for them to use, or if they need to use with somebody around them who could help them. And then syringe services programs are the third part of our National Drug Control Strategy harm reduction emphasis. A lot of people don't realize that syringe services programs, which used to be called needle exchange programs, provide a lot of healthcare services which are billable. They can provide wound care, they can provide pre-exposure prophylaxis for HIV, as well as PEP, which is prevention of post-exposure HIV, testing and vaccinations for hepatitis, HIV, and syphilis. And I just want to mention that there is now a syphilis task force that the Office of the Secretary, Assistant Secretary for Health has started up, because there's a very notable increase in syphilis and congenital syphilis, which crosses into the substance use disorder patient population. Okay, next slide, please. Substance use disorder treatment is a very important part of the strategy. If we were to appropriately screen, diagnose, and treat all the individuals with substance use disorder, similarly to how we treat chronic conditions like diabetes, we would be able to reduce the mortality associated with substance use by quite a bit. So there are 4 areas that we have actions under in the National Drug Control Strategy on treatment. One is including access to quality treatment. One is reducing stigma associated with treatment. Another is dedicating interventions for the most vulnerable, and we've done a lot of work related to including care for people who are in prison and jails. And then making sure there's a trained workforce to meet the strategy's treatment goals is also an important part of this. Next slide, please. So in terms of challenges with fentanyl in the xylazine era, many people don't know what xylazine is. The slang term for it, some people call it tranq. It is a veterinary medicine. It is not FDA approved for consumption by humans, but it is also not a controlled substance. Under the Controlled Substances Act, it is not scheduled. So cartels are sort of using a backdoor way to be able to obtain this, because it is not on the controlled substances schedule yet. It is a sedative. It causes prolonged sedation, and it does not respond to overdose reversal medicines because it is not an opioid. However, since it's mixed with fentanyl, and fentanyl does, we still recommend that fentanyl be, that naloxone or nalmefene be reimbursed, because those will help. Even if there's just a little bit of fentanyl in there, they should help with an overdose. Xylazine contributes to deaths with opioids, but alone it's generally not lethal. And one way to think about this is that naloxone can restore breathing. And you may not have a rapid return of consciousness when there's fentanyl and xylazine together, but as long as breathing returns, that is a good thing. And that is why we're recommending to continue with naloxone and nalmefene, as well as calling 911 and getting emergency services available. Now, my boss, the director of the Office of National Drug Control Policy, Rahul Gupta, has the authority to declare an emerging threat from a drug, and he declared in April 2023 that xylazine combined with fentanyl had disseminated across enough regions in the United States to qualify as an emerging threat. So I'm going to talk a little bit about some challenges that we're seeing. Next slide, please, related to fentanyl in the xylazine era. There are wounds that are contributing to negative consequences, in some cases even amputations. And these infections seem to be distinct from other injection-related wounds. The good news is that wounds seem to be likely to respond to care if xylazine use ceases. There are treatment challenges. We hear, because of fentanyl being so high of morphine equivalent, that people have very high tolerance to fentanyl. And in some cases, even with methadone, up to 200 milligrams of methadone may not be holding people if they are placed on methadone, may not keep their cravings at bay. That's a really high dose of methadone. We also hear that people who are placed on buprenorphine may have difficulties, and the recommended dose of 16 milligrams of buprenorphine as a limit may no longer be relevant. I'm going to talk about that in a second. NIDA hosted a meeting this summer to develop a research agenda on treatment of patients exposed to xylazine and fentanyl, and there's a link to a paper about that, that meeting. And SAMHSA is going to hold a meeting on dose limits for buprenorphine on December 11th. Now, people dependent on xylazine may be in extreme withdrawal even if they receive medications for opioid use disorder when they go in to receive treatment. And this will make treatment adherence for them very difficult, and also wound care very difficult, because there is no medication for treating xylazine withdrawal. So that's just something to keep in mind. Next slide, please. So I promised I would talk a little bit about regulations. There was a notice of proposed rulemaking on medications for the treatment of opioid use disorder and a supplemental NPRM on the same topic that came out last spring. And we are not 100% positive when the final rule will be out, but the unified agenda, which I encourage you all to take a look at regularly, the unified agenda is published in the Federal Register. It suggests the final rule will be out around the 1st of 2024. The agencies are not held to that date, but that is the date that HHS estimates this rule will be out. Some proposals that are in this rule include removing all the language concerning the need for a DEA registration, separate DEA registration or waiver to prescribe buprenorphine, because there was legislation that passed last fall that got rid of the waiver. So now all providers who are eligible in their state to provide buprenorphine can provide it for opioid use disorder treatment, not just for pain medication. There's an update of the regulation of an initial dose of methadone. It remains at 30 milligrams and not to exceed 40 milligrams on the first day, but there is an incorporation of a provision for higher doses if clinically indicated. And this is very important and relates to what I talked about earlier about people needing really high doses of methadone to get started. There were some pandemic provisions related to take-home doses that have been modified slightly, but those are going to be continued if the proposal in the notice of proposed rulemaking is accepted. And the requirement that opioid treatment programs maintain procedures to protect take-homes from theft and diversion, that was continued. There's patient education on safe transport and storage of take-home doses that was added. And there's also telemedicine initiation of buprenorphine that's discussed in there. So I just want to let y'all know that we anticipate this coming out and are very hopeful that you will be seeing an update of it soon. Okay, the final thing I want to talk about is the next slide, please. ONDCP has a number of reports and products that I haven't had time to talk about, and these are all linked here. The National Drug Control Strategy in more depth. Obviously, it would be great if you could take a look at the actions there. There is a methamphetamine plan that is out because Congress declared methamphetamine an emerging threat in 2022. There's a really terrific recovery-ready workplace toolkit that has guidance and resources for private and public sector employers. And I would encourage you, if you are an employer, even an insurance plan is technically an employer, to take a look at this, because people who go through treatment and into recovery, they need to have jobs and they need to have a workplace that's friendly to their condition. There's also a report on substance use disorder and pregnancy and how to improve outcomes for families. And finally, I mentioned a little bit about the fentanyl adulterated or associated with xylazine response plan. That is available too. Next slide, please. So that is all I have for you today. I really appreciate you listening to me, and my email is cspitznaz@ondcp.eop.gov. And now I'll hand it back to Sherry.
Thank you so much, Dr. Spitznaz, for such an extensive overview, such critical insights, and helping us to understand federal policy on the issue. We really appreciate it. Our next speaker is Sean Westfall. Mr. Westfall is Prevention Point Philadelphia's Overdose Prevention and Harm Reduction Coordinator. His interest in public health started in 2007 when he started volunteering in Philadelphia to provide free services for those experiencing homelessness. In January 2011, Sean began his journey by learning about emergency medicine, the life-saving use of Narcan, and soon afterwards reversed the first of many opioid overdoses in his community. Sean has been at Prevention Point for 5 years. In his current role, he is responsible for managing a team that provides education, harm reduction, counseling, and access to life-saving tools such as naloxone and fentanyl testing strips to people who use drugs. He manages the organization's Narcan inventory, ensuring distribution to 15 Prevention Point teams, and ensures that the entire staff of 170 people is trained in overdose reversal. Sean is also a certified basic life support instructor. His overdose prevention team conducts training and education throughout Philadelphia with a focus on people who use drugs. The team also provides training to providers, parents, partners, peers, and other advocates. Mr. Westfall?
Thank you, Sherry. I'd like to take this time to thank you all for attending. Thank you to the other panelists and organizers. So, yeah, what is harm reduction? So one thing we say is any positive change. It's a set of practical strategies designed to reduce negative consequences of drug use or any harmful behavior. It is a person-centered approach with a spectrum of different drug use. Empowers and affirms people who use drugs, the primary agents for improving their lives. It also prioritizes the right to health and safety for all people, offering options to those most marginalized within the health system. It recognizes that poverty, race, class, social isolation, past traumas, gender-based discriminations, among others, affect capacity to address drug-related harms. So I want to talk a little bit about the drug supply in Philadelphia. I want to give a shout out to the Center for Forensic Science Research and Education, also the Department of Public Health here in Philadelphia. So fentanyl has been the primary drug in dope since at least 2016. At least since 2018, xylazine has been the primary adulterant in dope. Fentanyl and xylazine combined make trank dope. So the ratios vary. Sometimes we're seeing anywhere from 1 part fentanyl to 0.1 parts xylazine, which is a rarity. Usually it's about 1 to 4, 1 to 7 maybe, up to 1 part fentanyl, up to 46 parts xylazine. So it varies quite a bit. It's in all the drugs or all the dope supply in Kensington for the most part, spreading throughout the city and the nation. More about the drug supply in Philadelphia. So in Philadelphia, the average amount of fentanyl and dope samples remained relatively consistent from the third quarter 2022 to the second quarter 2023. Xylazine content in dope samples continued to increase quarter over quarter, with the second quarter 2023 showing the highest average amount. In the first quarter and the second quarter 2023, solid crack samples generally contain more cocaine than powdered cocaine samples, and methamphetamine samples really varied. But mostly, for the most part, methamphetamine, but there was very limited data on methamphetamine itself. So as we're seeing as a trend, the dope is mostly xylazine, and it continues to be that way. We're speaking about overdose fatalities in Philadelphia. 2022 is the latest data that we have so far. We saw 1,413 people died from drug overdose in 2022. The second number, highest number, was in 2021 with 1,276 people died from a drug overdose. 83% of overdose fatalities involved opioids. Fentanyl, back in 2010, fentanyl was involved in less than 10% of drug overdose deaths. In 2022, fentanyl was involved in 96% of all overdose deaths. So this graph here kind of goes back to 2010, and goes to 2021. We see 2010, there was, and this really represents, at the medical examiner's office toxicology report, they find opioids, they find stimulants, they find other drugs. So, you know, in 2010, opioid and drug overdose deaths, including opioids, was 297. You go back to 2021, that was 1,052. So we're seeing a huge spike, consistently increasing throughout the years. So one thing I really want people to think about in how we respond to suspected opioid overdoses. You know, we've really had to change our game up a lot since 2018 or even 2016 when fentanyl took over the market. We constantly have to be on our toes, right? So no matter, you know, what the person may or may not have overdosed on, or even they use drugs at all, I want people to think about the basics of life support, right? So, you know, staying safe. We're calling 911 if the person is unresponsive. We're controlling any life-threatening bleeding if necessary. We're protecting the person's head, neck, and spine, especially if we suspect a spine injury. We want to make sure the person has an open airway so they can breathe. We're supporting the person's breathing. If the person doesn't have a pulse, we're beginning CPR. Have somebody grab the AED if available. And if we suspect an opioid overdose, we're giving naloxone. So I want to switch a little bit to the wound care issue that we're seeing. There's been a lot of different wound care clinics pop up just to address the need. This graph here goes back to 2010 or 2010 to 2020. We're seeing a spike pretty much across the board, especially for skin and soft tissue infections, sepsis. Xylazine does have a horrible effect on people. As far as wound care goes, we are thankful we have a wonderful wound care team here at Prevention Point. They recently had a paper published in the Journal of Addiction Medicine. So I know we have a limited time, so I'm not going to go too much into it. I encourage everybody to check that out. My hat's off to all those clinicians who are doing wound care out there in the street. They do an amazing job. So where do we go from here? You know, as mentioned earlier, talking about test strips, at Prevention Point, we distribute fentanyl test strips. We also distribute xylazine test strips. Depending on the legality of them in your locality is going to depend on how people can purchase them or if they can purchase them legally. So we'd like to see across the board. I know in Pennsylvania, fentanyl test strips are decriminalized statewide. We would like to see that nationwide and to also include other drug testing type strips. I got to mention overdose prevention. So if you yourself use any substance, if you know anybody that uses a substance, here's a couple of things that we like to encourage people to think about. One, avoid using alone. We know that most people die from opioid overdose, die alone, with nobody around them. We encourage people to use the buddy system and stagger their use. We encourage people to go slow, go easy, especially if they inject. They can always put more in, they can't take it out. We encourage people to avoid mixing other drugs with opioids. We want people to understand and respect their tolerance to opioids, especially fentanyl, especially people getting out of jail or treatment. Have to understand that they've lost a lot of that tolerance. If a person doesn't use fentanyl, but uses other substance, we want them to get in the habit of testing their substance with a fentanyl test strip. Always carry Narcan, know how to use it. Here at Prevention Point, last fiscal year, we trained 1,300 people in how to use Narcan, and we've distributed just over 95,000 doses of Narcan for free. And a big part of how we do that is we like to do it handed out little or no barriers whatsoever. And we've been able to do that because our partners at the state has helped us get that Narcan out there. And I really can't say enough good things about them. And hopefully people in other states, you know, also have those type of resources where they can get the naloxone they need to be able to distribute. Some of the services we provide here at Prevention Point, 30,246 individuals served, 394 HIV patient visits for ongoing medical care, 1,775 HIV tests administered, 516 prescriptions for PrEP, 7.9 million syringes distributed. There was 1,103 wound care visits, 10,814 social service was provided, and 357 individuals newly inducted into MOUD clinic, which is up 60% over the last year. I want to thank you guys so much. I appreciate your time.
Thank you so much, Sean, for helping us understand the value and power of harm reduction practices when it comes to protecting the health of people who use drugs and how the approach can improve lives. Our next speaker, our final speaker today, is Doug Henry, PhD. Dr. Henry is Vice President of Psychiatry and Behavioral Health at Allegheny Health Network. Dr. Henry's professional career began at the Presley Ridge Schools on Pittsburgh's North Side, working with children and adolescents with autism spectrum disorders. In California, he was a school counselor for Klein Bottle Youth Services, serving as an acute psychiatric inpatient clinician at Cottage Hospital in Santa Barbara, and a counselor at Services for Adolescent and Family Enrichment in Southern California, as well as a psychologist and supervising psychologist for Santa Barbara County's Alcohol, Drug, and Mental Health Services. He has more than 20 years of experience in applied psychology, including inpatient, outpatient, and administrative assignments. Dr. Henry joined Western Psychiatric Institute and Clinic as the clinical administrator for UPC, Child and Adolescent Behavioral Health Services, the UPC Center for Autism and Developmental Disorders and the UPC Center for Eating Disorders. He has been at Allegheny Health Network for 6 years and attracted by the emphasis on patient-centered treatment at AHN. More recently, Dr. Henry has accepted a role with the Highmark Health Office of Clinical Transformation. Dr. Henry?
Thank you, Sherry. And my apologies for that long bio. Obviously, you did not get the brief bio there, but appreciate it nonetheless. So I'm a clinical psychologist by training and background and work for Highmark Health, which is the third largest Blue Cross Blue Shield insurance company in the United States, and primarily in West Virginia, Western New York, Delaware, and Pennsylvania. My other employer, Allegheny Health Network, where I serve as the Vice President of Psychiatry and Behavioral Health, is a 14 hospital network in southwestern PA and western New York, serving roughly 2.5 million people. So to simplify, my job for AHN is to plan and strategize around providing behavioral health access for a population of about 2.5 million. And in my payer role, Highmark Health, I do the same function for about 8 million members. Next slide, please. So I'll talk just a little bit about both a payer and a provider perspective. What can and should we be doing about the ongoing opioid epidemic and the emerging epidemic of combined molecules into deadly poisons that are leading to an increased frequency of overdoses. So Highmark has a three-pronged strategy, not surprising. And I think that prevention point in the national government is no different. And thank you to Dr. Spitsness and Mr. Westfall for excellent presentations, by the way, as well. Next slide. Some of the things that we have done at Highmark is to partner with our local FBI offices to create videos to prevent drug use, and they're disseminated broadly. And these videos are of quite high quality and quite engaging for young people, capture their attention. A lot of FBI badges and dramatics involved in the video. And that has been viewed by a good number of people in West Virginia, as well as a number of students in Pennsylvania, about 9,000 additional students. In addition to these efforts at primary prevention, the Allegheny Health Network also has launched a school-based behavioral health program that has a mindfulness-based curriculum, but lots of drug and alcohol prevention content. And the program includes both clinical components and psychoeducational components. In other words, we deliver psychotherapy and psychiatry on site in 50 school districts in Western Pennsylvania, and are looking at initiating in the state of Delaware now as well. So we provide those professional services to those top of the pyramid students who need it, but we provide psychoeducation and prevention strategies by pushing into the health classes so that we are touching the entire student body and actually the entire school community. So as I mentioned, we have actual physical presence 40 hours a week at more than 50 school districts in Western Pennsylvania now. And so that's an additional 250,000 students that we are reaching with our prevention efforts. Next slide. Community support. Before I get into community support, I want to talk a little bit about prevention, because the slide doesn't have a key thing that we do. And that is that we provide prescribers data. So we are pushing to prescribers on a daily basis. These are physicians or advanced practice providers, or sometimes called mid-levels, that are prescribing opioids. And what we push to them is where their prescribing patterns fit by percentile compared to their peers across the United States and within their own region. The point being that if you give the physicians that feedback that their prescribing practices are out of the norm, say that they're in the 70th percentile of aggressive opioid prescribing for similar clinical problems and similar CPT codes, that information is highlighted for them very clearly in red in data that we push to them on a daily basis. And we have found that teeing that information up for them, presenting it in a very digestible, easy to understand format, and being very clear while not being heavy-handed and respecting the sanctity of the doctor-patient relationship. Just providing that information has led to a sharp decrease in the amount of opioids being prescribed, as well as the number of days supply of opioids that is dispensed at any one time. So really proud of that data-based effort at prevention. In terms of community support, we're extremely active in our community. We know that a community that is more well is good business for the payer and good business for the provider increasingly in value-based reimbursement paradigms. So in just the past 3 years, Highmark has committed more than $4 million to community organizations and programs fighting the opioid epidemic in Pennsylvania, Delaware, West Virginia, and New York. And something else that I would recommend to all of the administrators for behavioral health organizations or risk mitigation organizations that are listening in today, and that is to harness the power of your own team. So at Highmark, we have 40,000 or so employees, and we have many, many people that have been touched by addiction in their families or personally and are in recovery, or who otherwise are very concerned about the epidemic of drug use in the United States and want to do something. And so we've created a forum for them that we call Learn. And at the current date, we have more than 600 regular participants. The anchor activity for the Learn program is monthly speakers, and we invite really high quality speakers from both within our organization and outside. And I think that the quality of that speaker series once a month is really that initial draw. That's what causes us to go from 200 to 600 and will be up to 1,000, I have no doubt, before the end of 24 and beyond. But people are looking for ways to impact their community. And so we have many subcommittees of the Learn program that focused on philanthropic efforts, on new ideas, new ways of engaging the community, and new angles as far as new tech that might not be widely known. So to harness and create a forum for your own staff and the energy that already exists within them to do something positive has been incredibly constructive and is the most can be the most inexpensive, the most effective, inexpensive intervention that you can do if you have a relatively large organization. Next slide, please. Treatment. So treatment is the second of our three-prong approach: high quality SUD treatment, and then the community supports to maintain the relationship and the engagement in the treatment. Next slide, please. So this is probably the most important thing that we in the United States can do at this point in time to combat the SUDS epidemic, and that's increasing access to evidence-based treatment, and in particular for today's topic, to medically assisted treatment. So in 2020, we launched a technology-enabled opioid use disorder program in West Virginia that was really groundbreaking, doing remote MAT, and West Virginia presents certain geographical challenges and population density challenges. And so digital treatment access was absolutely a priority and a prerequisite for the approach, a population health approach that we needed to take. The participants in the program have access to a multidisciplinary staff, a variety of different supports through smartphone, tablet, or computer. And we also have kiosks and privacy booths where other access can be gotten at certain points or at certain places in population centers if people do not have their own technology. So getting people engaged in MAT, maintaining them on MAT is hugely, hugely important, probably the #1 thing to emphasize today. And I would also suggest that bringing MAT access to areas and regions in the US where they are needed. So there may be the illusion of access in certain areas because you have 1,500 providers and that looks like enough for the cities the size of Pittsburgh, but where those offices are, where people can access those, their proximity to homeless camps or groups of unhoused people living together, that's what really matters in making sure that there is low friction access to that MAT. Next slide, please. In late 2020, Highmark and Axial Healthcare is a subsidiary of a company that is one of our partners called Wayspring. Axial has gotten into the business of prevention in terms of providing software that tracks network physicians' opioid prescribing habits very closely, and I mentioned that earlier. That is the software that we use to create those daily feeds to primary care and orthopods and other physicians that are commonly prescribing opioids, and that data is just absolutely essential. Another essential component are the boots on the ground, the peer support network that is cultivated across our 4-state areas so that people have tangible and 3-dimensional, not 2-dimensional like we're talking right now, but people that they can relate to and people they can have a cup of coffee with, people that they can call when they're having a crisis or in the throes of cravings. These efforts have led to a reduction in opioid-related overdoses as more individuals diagnosed with SUD are linked with MAT. Next slide, please. So this is another point of emphasis, and probably the second thing that I would really encourage providers and payers to do, and that is to monitor the data very, very carefully. First of all, put in the time, effort, and money to get the data, to isolate the data that is going to tell you how you're doing in your battle against the opioid epidemic, and monitor extremely closely. So to isolate the data in the way that I'm showing here, and then to pay attention to it and take action based upon it. So this is absolutely critical, and this is really looking at prescribing patterns across our 4-state area and as a network broadly. And this is different than the data on individual prescribing patterns that are ranked by percentile that will tell a physician if they're in the 50th percentile, the 30th percentile, or the 90th percentile for dosages and frequency of prescriptions for similar CPT codes and similar diagnoses. This is that's the prevention component. Once somebody is on opioids, this is the monitoring or the level of pinpoint monitoring that you need to get into. And so new opioid fills per 1,000 citizens, and this is the one that we're probably the proudest about right now because we've moved the needle here so much. Initial opioid prescriptions being less than a 7 days supply. It used to be 30 days, usually at a minimum, sometimes even 90 days, and that was one of the contributing factors to the epidemic in 2016, 2017, and we've moved the needle on this significantly, up to above 93, 94% of all prescriptions supported by Highmark are now less than 7 days supply for that initial opioid prescription. So evidence of MAT following overdose is another opportunity for payers and providers alike. So we do inductions, having the capability to offer Suboxone post-OD to patients that have presented at our emergency departments. This needs to be become standard care, not exceptional care. We also have peer supports and a social worker that engage all members that have come into an ED post OD, and that also is incredibly helpful. The idea is to get the induction going there, the Suboxone treatment underway in the ED, and then create an appointment at a very close office to continue the MAT the following morning. So anything less than that, people fall between the cracks. But if you are there and you can induce on the spot, strike while the iron is hot, so to speak, and induce on the spot, and then offer next day follow-up, you're giving people a fighting chance at sobriety. Next slide, please. Okay, we've gone over primary prevention, safe prescribing, our philanthropic efforts to bolster community supports. At AHN, we do things like we have a street psychiatry team that goes every day to different homeless encampments or unhoused encampments in the Western Pennsylvania area. We too, like Prevention Point, hand out Narcan, no questions asked. Just absolutely handing out Narcan wherever we go, wherever we possibly can. An interesting thing that we do that we've gotten a lot of positive response for is we bring a mobile unit to the local county jail, and as residents are leaving, those residents that had been diagnosed while they were incarcerated with an OUD are offered the opportunity to begin medically assisted treatment before they leave the parking lot. And then again, that next day follow-up saying, okay, we've got an office right around the corner where you can get Suboxone tomorrow morning. That's the kind of thing that makes a difference. So we try to develop macro strategies and population health management strategies at the Highmark Health enterprise level, and then really allow and encourage providers to develop their own region-specific solutions, like this mobile team that we have in the parking lot of the county jail. So that kind of top-down support, while allowing enough freedom for the local regions to implement the programs tailored to their community needs and tailored to what's happening with their population, is the right way to go. Next slide, please. Okay, questions. I'll just summarize very quickly. What's unique or differentiating about Highmark's approach to these huge societal challenges are the use of data in both prevention efforts and in prescription monitoring efforts, and the integration of tech, such as the early adoption of remote MAT service availability in West Virginia, and we continue to spread our footprint with remote MAT, and have found that it works better than we had thought, and we really did learn this in the COVID pandemic, that this can be safe and effective. Lastly, the emphasis on emerging technology. We're working with a company right now that has a wearable that will predict cravings. So episodes of crisis for users, and will predict an episode of craving 4 to 6 hours ahead of the peak of the craving, so that additional support can reach out and engage the member. Time for questions.
Thank you so much, Dr. Henry, for that broad perspective on Highmark's obviously highly successful initiatives to address prevention at the community level and to provide more access to care. We have just a few moments left for questions. I'll go back to Dr. Spitsnaz, as she was our first speaker. We've had many questions come in. If the speakers would like to come back on camera. Dr. Spitsnaz, one of our audience members would like to know what policy changes are necessary to better match existing treatments such as buprenorphine and methadone with fentanyl and polysubstance use.
Thank you, Sherry. I'm happy to answer that. So I mentioned that SAMHSA is holding a meeting on December 11th to examine the data regarding dosing limits for buprenorphine in light of the polysubstance use, specifically the xylazine and fentanyl crisis. So that's one example of something that may be needed. And as you may be aware, there's no medication treatment for stimulant use disorder currently. That is why FDA released guidance on stimulant use disorder medication development this fall. That guidance can be reached via the Federal Register, and the deadline for comment on that actually is today, Monday, December 4th, if people are interested in taking a look at that and commenting. So in general, I don't know that this necessarily is policy, but we do need to put funding behind research on these different topics. Thank you.
Thank you. Mr. Westphal, we have a question. What do you feel is the most important action item necessary to reduce or reverse the overdose trend? What is that one powerful thing that we might be able to do?
I believe the verdict's still out on what's the one thing. You know, I personally believe that we need to use, or maybe should use, every tool in the overdose prevention toolbox that we have that is proven to save lives and also reduce harm in the community. With that being said, I think the move to naloxone to moving to over the counter is a huge step as far as accessibility goes. I know we have a lot of work to do to get the price to go down and make it more accessible. Hopefully the insurance companies will continue covering it. But I think the naloxone accessibility is a huge part of that. Also, education. I can't stress that enough too.
Thank you, Mr. Westphal. Dr. Henry, from your perspective, do you see changes in our society and how we interact with each other that might be contributing to the sudden uptick in the overdose crisis that we seem to be seeing in recent years?
Yes, without question. Thank you for that question. There are a number. Perhaps most salient is the epidemic of loneliness that is occurring right now. So 61%, for example, of young people under 21 in the United States report suffering from chronic loneliness. And I often tell my team or psychologists that I'm training that substance use disorders exist in emotional spaces in people's lives where relationships with other people should be. And as we become more fragmented as a society, and certainly the pandemic did not help this, and more separated, whether it's by political opinion, geography, or lack of social skills, then the drug problem is going to get worse.
Thank you so much. Unfortunately, we're out of time today, but I want to offer a very large thank you to our panelists who did an extraordinary job of helping us understand this very difficult and important issue and offer some really high impact solutions. And thank you to our audience for joining in with our discussion by sharing your questions. Your feedback is important to us, so please take a moment to complete a brief survey that will pop up on your screen right after after the event. Please also check out our other resources available on our website, including a recent infographic on this topic, combination drug use and the overdose crisis, as well as our webinar page, which will have the presentations from our speakers and links to some of the wonderful resources that they've shared today. Again, thank you for your time and have a wonderful afternoon.